Hello, my name's Jacqui Fletcher and I'm the clinical lead for the Stop the Pressure programme. And I'm delighted to be joined today by Fiona Downie, who is a lecturer at Anglia Ruskin University and previously a consultant in tissue viability at Papworth Specialist Cardiovascular Hospital, and also by Andrew Sharpe, who is advanced podiatrist at Salford Care Organisation. We're going to be focusing today on thinking about central and peripheral risk factors. And rather than just thinking about diseases, thinking about specific symptoms you might look for or particular medications you might want to think about. So if I can go to you first, Fiona, can you tell me, when we're thinking about perfusion, what might you be looking for clinically with a patient?
Okay, yes, so you would obviously be looking at the physical signs, and I might leave that to Andrew to discuss with the sort of lower limb and foot. But also we'd be looking at their past history. That's really important when we're doing an assessment. So did you want me to talk a little bit about things we'd be thinking about in their past medical history, Jacqui?
That might be a good idea, yes.
Yeah, so when I was thinking about this session, I was thinking about medicines that we don't always associate with perfusion issues. And obviously the obvious one is vasopressor drugs, which, for example, is noradrenaline, and patients receive these when they're critically unwell in ITUs. And certainly we saw many patients very unwell during the COVID pandemic, and we did see an increase in darkened areas to the lower limb area. So it is important to look and see what your patient's past medical history is. If they're in hospital and they've been in an ITU setting, have they been on vasopressors? But causes of darkened, blistered areas on the legs and the feet, can be in other parts of the body, is when we have warfarin-induced necrosis as well. And this can be quite specific to, it's often ladies, and it's often ladies that are perimenopausal or menopausal. So it is something to be aware of. Look and see if your patient is on warfarin or they've been newly started on warfarin. Also, other drugs that we think about are nicurandil, which is cardiac drugs, and it's used as a vasodilator with cardiac disease, but this too can also cause darkened, ulcered areas to the lower limbs, and that could be in areas where patients would receive pressure as well. So it is important to look at this aspect when assessing.
Thanks, Fiona. Andrew, what about from your perspective? I mean, obviously as a podiatrist, you focus very much on the lower limb.
Yeah, absolutely. Yeah. So in terms of for signs, and if I start with the signs and symptoms first, is that the logical place? Okay. So, I mean, for us as podiatrists, we quite routinely feel for pulses, but it's one of them things that over the years, people, I think, have felt embarrassed to say that they can't feel a pulse. And I think that the message that we're trying to get across is that if you can't confidently feel the pulse, it might not be there, and we need further assessment. So first off, we look at kind of chair-side assessment of pulse palpation, look for skin changes, particularly ulceration or any deterioration in a wound. Other kind of, so those are probably more our hard markers when we've got absent pulses and definite skin loss and tissue damage and necrosis and gangrene, etc. You then hear in the text and talk of what I would refer to as sort of a little bit more soft markers, where people talk about the dryness of the skin, the cooler limbs, which are very much more subjective and can be more individual specific. So it's sometimes that can come down to knowing the patient well to see if the changes have occurred over time. So the kind of the thick and brittle, dry nails and dry skin can be good markers, but aren't ones I would hang my hat on if you don't know the patient very well. Things like pulse palpation and new incidences of pain or ulceration are key factors really there.
What about limb elevation? You know, we used to do, we'd like the patient.
Oh, of course, yeah. So it's a great, things like the Berger's test are great indicators to help differentiate between an ischemic flushness of a red or an infected flushness of a red. But also, just by elevating the limb and you see it flushing, that's not a normal thing to happen in a limb. So those can be other good indicators. And classic ones like capillary refill time as well. But again, if not done well or not done regularly, they might confuse your message sometimes and make the problem a little bit more difficult. I think if you stick to the kind of the bench, what often we talk about in podiatry is the 3 Ps to think about whether a pulse is present, whether palpable, whether it's what its phases are like with a Doppler, and what the actual pressures are like when we start to look at ABPI or toe pressure assessments. And I think if we stick to simplistic methods, then when you start to get a bit more skilled, capillary refill can be important. Berger's test is a good one just to help you with differentials, and these other things come with experience. But I think the difficulty is gaining your experience will only come in time, and if you're the first time or first couple of times doing these type of assessments, you wouldn't be expected to be an old hat at it or an old hand at it, or the terminology is.
Fiona, can I just ask you, when we think about perfusion, we tend to think about blood supply, don't we? But what about respiratory function? If a patient has really reduced oxygen saturation, is that something we would consider in the equation?
And that's absolutely something we should consider. And that goes alongside your patient that is severely dehydrated or has any vascular issues at all. So if they are, they've dropped their blood pressure, they are they're very unwell, so they're feverish, they're dehydrated. All of those types of things will affect the amount of circulating volume of blood. So yes, that is a perfusion issue that we wouldn't traditionally think about in that side of things.
And would that include, the patients with the very swollen legs or the lower half edematousness that we would expect poor perfusion, even in the sacrum, the patients with the heart failure?
Yeah, absolutely. So patients that have got lower limb edema, or they've got edema around their trunk area, this puts them greatly at risk, because not only is their perfusion poor, but also they have got this massive strain on their skin. So their outer protection is being stretched to the limit, if you like. And one of the other things with heart failure in particular is that skin suddenly starts to blister, and then it will break down. And then you're on a fine road to getting an infection in there and managing something else completely alongside the damage from pressure and shear.
So I think that's one of the things that gets missed, isn't it? We always think about the blood supply, we always think about arterial assessment, but there are lots of things that can compromise the blood supply. Even things like patients with the large abdomens, that can press on the femorals quite a lot and reduce the blood supply down to the leg.
Yeah.
And I think we just need to get better at looking at the signs that we see, as well as thinking about what the disease processes are.
Yeah.
So if we accept that perfusion is a challenge, what kind of things do you think as a clinician we can help to do to reduce these risks?
Yeah, I mean, if you're managing a patient who's got perfusion issues, one of the first things you do need to look at is what's happening with their fluid balance. Now, of course, they might be on a restricted fluid balance, so you would always have to speak to the physicians managing their treatment. But it's certainly one of the first things that you should look at. Then obviously the really obvious thing is, if they've got perfusion issues, you offload, and you offload and you offload and you offload as much as you possibly can. You also need to be thinking about a good skin regimen. So what are you doing with their skin? Are you using protective barriers? Are you moisturizing the skin, adding moisture back into that skin? But alongside a good skin regimen is just about cleansing it, to making sure that it's clean, but also that your patient is hydrated, that they are taking fluid on board. And of course, it's all your universal precautions to prevent infection, because a patient with impaired perfusion is much more at risk of any break in their skin becoming infected. So universal precautions have to be carried out.
And from your perspective?
Yeah, I think that's a real great comment about the skin check, because one of the important things for us, especially when someone's acutely unwell and an inpatient, is this principle that was first talked about in Scotland about check, protect, refer, because often the foot isn't looked at. So when skin is checked, people are checking all over, but not necessarily the feet, because for any number of reasons we don't like feet, or but this element of getting the skin perfusion right in checking the feet and recognizing early the whole stop pressure campaign of reacting to red and that type of thing. We don't want to miss those opportunities. And what's key in I mean, even if someone's not necessarily acutely unwell and they're in bed, one of the main issues we see in podiatry in terms of the diabetic foot is that loss of protective sensation. So we see damage occurring without the patient aware of damage occurring. If we sat here now for, I don't know, 3 or 4 hours, we'd be shuffling our bum every so often because we would. But we don't see that in the diabetic patient. So knowing that people are checking skin and including the foot in the skin check is one of the key things, really. And recognizing that if somebody is a risk, that we actually do refer them on. So they check the skin, protect them in the offloading mechanisms for what's suitable at the time, and refer them on to appropriate services.
You mentioned a really important point there, Andrew. You talked about react to red. And when we're talking about poor perfusion, we're often talking about darkness or duskiness. How does that apply in patients with dark skin tones?
Yeah, it does get a bit trickier, and it's recognising the subtleties there rather. And this is the key. This is the key, I think, to checking a contralateral limb as well. So we don't just get focused on looking at the one area. We get used to recognising the pigmentation for the patient. And if you're doing a full skin check, for example, or a full lower leg check, because I'm not going to go and check someone's bottom with the best love in the world. If I'm doing someone's leg check, I will check the skin pigmentation between the two limbs, and that can tell you a lot as well. Because it is a difficult bit. I know, Jacqui, you've done quite a lot of work with this and in raising the profile, and it is something we're becoming more aware of, that we are missing subtleties in change because we think in red and not necessarily darkened or discoloration. And yeah, so it's a very important thing to think about when we do check, that we recognize the ethnicity of the patient and the skin pigmentation as we look over it.
Yeah, and I think we're all learning very rapidly about this, aren't we? But this is a particular area when you're talking about perfusion, and one of your key signs is not redness, it's duskiness. That's much harder, isn't it, on dark skin? Was there anything you wanted to add on that, Fiona?
Yeah, I think Andrew was talking about it a little bit earlier, is the fact that we shouldn't just be looking, we should be touching our patients as well, with permission, of course, because the feel of the skin can give you lots of clues as to what's going on. Is it woody? Is it indurated? So it isn't just about looking for colour changes, but it's actually what can you palpate on the skin. You can't do an assessment of the skin without touching the skin.
And temperature as well is really important, isn't it?
Yeah.
Absolutely. And that becomes even more important as well when you think about the difficulties in care settings or when they're in their own home and they might be in a contracted position, and the physical seeing, and even with mirrors and things, the physical seeing is difficult. So having a feel around can tell you so much. I think we forget our hands is probably the greatest tool that we have in our bag. We all want a nice posh new shiny tool, but actually just by feeling, touching and moving tells us so much.
Yeah, and that's a really important point, isn't it? We're always looking for the next assessment tool or gizmo, but the kind of put your hands on the patient, talk to the patient is also really important.
Definitely, yeah.
The final thing I was going to ask about is there anything we can do to encourage patients to recognise that their poor perfusion causes them to be at risk? What kind of hints and tips should we give to them?
I think that my mantra always, for whatever, if it's a healthcare professional or it's a patient or it's their family, is educate, educate, educate. So talk to them about why this is a risk, and give them little things they can look at. That Andrew's just been describing, is one leg a different colour to another leg. Just these very small, subtle signs that if you're looking at yourself every day, you might miss. But if you look with a more educated mindset, then you can pick things up. So for me, it's always, you know, educate, educate, educate. Don't miss an opportunity to do that if you can.
Absolutely. What I would add, and it's something we haven't done historically very well, but we're starting to look at more and more, is just getting people to do some movement, because often in the diabetic foot and people who are chair bound or house bound, they're not doing any movement. So it's just doing the chair side exercises to help with the perfusion, to help, and any movement is going to help reduce that, whether it's venous fluid or lymphatic fluid or it's arterial supply. Getting those muscles moving even a little bit is going to help in that prevention bit. And I think this to me is our next big kind of area that we need to try and move towards, because we've spent so long, especially in the diabetic foot, telling people to sit down and get off the foot. Now we need to tell them to, but while you sat down, keep moving. And we just need to kind of have that conversation in a way that doesn't make us look completely foolish for telling you to sit down, but no, definitely. And it's interesting when you see a physio's approach to this in terms of real small exercises that can help make a big difference in getting somebody a bit more, even just sitting up better or just moving about a little bit more.
And I think it's a really important point, that, isn't it? You know, I think we need to be careful with language, because I know one of the things that quite often turns patients off is telling them they've got to exercise. But if you tell them to move more and give them examples of what you mean by that, so even if it is leaning forward or leaning sideways or just picking your foot up and down, then that can make a real difference to what they do. And as you said, it can help increase the perfusion. It can, by helping reduce edema, maintaining muscle function. There are so many things that it's better for, as well as the overall reducing the load in pressure ulcer prevention, because at the end of the day, that's what we're trying to do, is prevent pressure ulcers. So can I thank you both for your time? I think it's been a really useful way of thinking about perfusion differently. We're not just thinking about ischemic heart disease. We're not just thinking as the patient had a CVA or an MI or are they diabetic. We're thinking about really practical things. So thank you once again. And we hope people enjoy using the Purpose T. Bye, everybody.
Thank you.
Bye.